I want to welcome members of the public. I'm going to sit around here. I apologize for the setup of the room. I think we're thinking that way, but we're going to be focused on some of our colleagues who are joining remotely. So my name is John Scott. I'm the Medical Director for Telehealth Services at the UW Medicine. I'll be leading our discussion today. I thought what we could do is start off with introductions of members of the collaborative. Maybe if we could just start with, we'll start with Senator Becker, and we'll just go around here, and then start with folks on the video.
I'm Senator Randy Becker from the 2nd Legislative District, and if you ever come down to visit Mount Rainier, you're in my district. So I think it's one of the most beautiful districts in the whole state, but that's my bias. I am the sponsor of the telemedicine bill, and the reason we're here.
All right, welcome. Hello, Jeff.
Hi, I guess we're back.
You're back.
Yes. Sorry about that. We kicked the wire. Well, we just did introductions, so maybe I can just go around. Folks who are joining by televideo, ask you to introduce yourself. Maybe we can start with Dr. Jones.
I'm Jeff Jones. I'm a family doc in Newport, Washington. I always give bonus points to if folks actually know where that is, but it's an hour north of Spokane.
Thanks, Jeff. Maybe we go to Dr. Frances Guff.
Good morning. I'm Frances Guff. I'm the Chief Medical Officer for Molina Healthcare here in Washington. And I've been in the telemedicine space for about the last 16 years. And most recently trying to bring some of these great technologies into Molina and some of our members. So thrilled to be here. Thank you.
Great. And Frances helped to write some of the guidelines for the American Telemedicine Association, so we're really pleased to have her experience and expertise. I'm sorry I don't know people by sight yet. There's one other person who is joining by video. Can you please introduce yourself?
Sure, this is Susan Stern. I'm the division head for emergency medicine at the University of Washington. Actually, I'm representing Washington ACEP, which is the American College of Emergency Physicians. I'm very excited to be joining the group. Appreciate the opportunity. We at Harborview and UW certainly do a lot of outreach within the emergency department to other rural sites. And I think there is a lot of room and opportunity in the space of telehealth. Within emergency medicine, opportunity for, helping people in their communities, cost savings, as well as improving care for higher end injuries and illnesses in rural areas.
Thanks, Sue. Adam Romney, do you want to introduce yourself?
Yes, this is Adam Romney. I'm an attorney at Davis Wright Tremaine. I work regularly in the telehealth field, both with providers and other organizations within the state and outside the state, and I'm very happy to be included in this group.
Thanks, Adam, for joining. I'll have some other people introduce themselves. I'm sorry I don't know you by sight yet.
I'm Lori Wakashiga, and I'm with Legacy Health out of Salmon Creek, Washington, and I'm the program director for telehealth and regional outreach.
Great, thanks, Lori. And I don't know if we have Senator Cleveland. Senator Cleveland, are you by phone or by video? And also, I may have had Scott out on the peninsula. Scott Kennedy, would you be able to join us?
Yeah, I'm with you. I'm Dr. Scott Kennedy. I'm the Chief Medical Officer here at Olympic Medical Center on the peninsula, so SWIM in Port Angeles primarily. And we have a rural referral hospital, Soul Community Hospital. And we're using some telemedicine now in limited application with telestroke and telemovement disorder. And we have other capabilities that are beginning to show up in the community with the ECHO program and work with hepatitis C. But we're very interested in, I'm very interested in working on this to help develop access to care rural communities having more access to some of the specialties, but also the efficiency of care for things that we already deliver. And so I'm very glad to be part of this group. Thank you very much.
Great. And I know, Senator Cleveland, you're on. Maybe I can ask Randy at UW. Randy, if you could just open her line. The other thing, Senator Cleveland, there is a little mute button in your lower left corner. You may have unintentionally muted yourself.
Thank you. Yes, good morning. This is Senator Annette Cleveland coming to you from Vancouver, Washington in the 49th Legislative District. I'm pleased to be a part of this effort, excited for the work ahead, and I serve as the ranking member on the Senate Healthcare Committee, and also in my career, my other life, away from the legislature, I work in the healthcare field. So again, very pleased to be a part of our work ahead.
Great, thank you, Senator Cleveland. Wondering if we have Representative Bergquist also on the line, on the call?
Yep, Representative Steve Bergquist from the 11th District in Renton, Tukwila, South Seattle. I've been the prime sponsor of telemedicine bills in the House for the past 4 years, and I was hoping to be there today, but I have 2 kiddos that child care fell through on. So appreciate the opportunity to be here.
Great. Thank you, Representative Bergquist. Anyone else on the line or joining remotely who wants to introduce themselves?
This is Mark Delvacaro. Can you hear me?
Yeah, go ahead, Mark.
Hi, this is Mark Delvacaro. I'm the Chief Medical Officer at Seattle Children's, and we have a variety of telehealth initiatives, and happy to join the call and the group. Thanks for having me.
Thanks, Mark. Anyone else on the line wants to introduce themselves? Great. We have one other arrival here in person, Cara Tell. Cara, do you want to introduce yourself?
Hi, my name is Cara Tell. I'm with the University of Washington. I spent the previous 15 years as the Director of Telehealth Services and worked with John for a few years. And now I'm with the Department of Psychiatry. I'm the Associate Director for Psychiatry, Consultation and Telepsychiatry, and the Integrated Care training programs. So I'm happy to be here and see some familiar faces that I've worked on over the last few years and getting some inspiration.
Thanks, Cara. And Cara is also on the board of the Northwest Regional Telehealth Resource Center, otherwise known as the NRTRC. I think Danny, you also have quite a bit of experience on that. That's another resource that I think everyone should know about. It's much more of a Pacific Northwest kind of resource, but certainly hopefully be linking our website to yours and referring people to that. They have monthly webinars. They have a great conference, usually every March in Seattle, where there's speakers from all over the country and the world. So as that date approaches, we'll definitely be advertising for that. So great. So I think what we were going to do is, unless there's anyone else who needs to introduce themselves, we're going to turn to the task at hand, and that's really talking about what do we want to do with this collaborative. I mean, we've reviewed some of the languages within the bill, talking about sharing best practices, and talking about some of the non-traditional ways that telemedicine is being delivered. And I think the ancillary question is, do we want to have kind of a written charter, a vision statement, or some goals of what we hope to achieve? So maybe what I'll do is I'll open it up first to folks here in person, and then I'll open it up to just for procedural issues, and then open it up to folks who are joining remotely. And some of us already got a head start on this, so if you feel like we're kind of roaring out of the gate, that's because several of us did meet a couple months ago to talk about this. But maybe, Senator Becker, do you want to kick it off?
I wouldn't mind that, of course. So first of all, I have to say I'm totally amazed at how many people applied and what great opportunities we have in Washington State with the minds that you all have and your experience. And my goal and my vision is just a little part of this, but I think that we're only touching the tip of the iceberg right now in what we've done in telemedicine. And I think that telemedicine will be something that will change, be an ever-changing product that as technologies advance, whatever we do, we have to make sure that we develop systems that are going to be flexible enough we can make those changes as technology advances. I have kind of a big picture view of this, and you guys get to fill in all the detail and the important part. But my big picture view of this is ultimately creating a center of excellence so that it's peer-to-peer, provider to provider, and reaching in and having the ability to get information out to the provider network, whether it's mental health or physical health or specialty care, whatever. And having it as a resource of an educational resource portion, but then those non-certified or the certified employees would have the ability to have the reach in as well. So I look at it long-term as this wonderful center for providers to be able to have access to the most current technologies, information that providers have come up with. And that's my big picture. So.
Senator Becker, I know there are several other states around the country who have something like this. I was wondering if you would be able to contact us, like Senator Franklin in Missouri, or.
I have not had a chance. I'm doing what when we're down in Olympia, have to say is an off-site or off-campus activity. So I'm running for re-election, trying to do that and balance this. So just a little bit of my history, though, is that I came out of the medical field. I was a medical practice administrator. And so I really want to make sure that what we do is listen to the doctors. And I always told the doctors that I'm the pencil pusher, you're the clinician, and it takes us as a team to do this, but it should be driven by the providers. And so, no, I haven't had a chance.
Okay. All right, we'll make sure. And maybe later on, after people have had time to speak, I do want to share what other states have done. We'll go to the New Mexico website, but I do want to make sure that, first of all, we start with kind of a blank slate before we kind of get pigeonholed. So other thoughts, ideas, what do you guys think is important for this collaborative, for the greater good?
I've worked at Swedish for a number of years in various roles, including delivering healthcare to the remote areas in Idaho, Montana, Alaska, and currently running telehealth programs out on the peninsula. And I just really appreciate compact agreements and the possibility of reaching our region. As a major tertiary quaternary medical center, we see a lot of healthcare needs in our setting. The truth is, much of the care that we deliver could at least be providing continuity of care once people come for major procedures, et cetera, and keep people back in their homes, whether it's on the peninsula or Nome, Alaska, et cetera. And so making that possible for providers. When I worked in Alaska with our transplant team and Montana and Idaho, I continue to carry licenses because it's not easy to get licenses across all these states. But how do we make things transportable? And our technology is definitely there and really cool and getting better all the time. But how do we lift some of these barriers safely and responsibly so that we can deliver healthcare and really reducing the overall psychological distress for people in terms of travel, but also keeping them local if possible. And obviously the cost of going to other states for healthcare.
I think what we're going to do, just for sake of procedures, we're going to have a time for public comment at the end of our meetings. So not to be too exclusionary, but we do have a lot of people on the collaborative. So we're just going to have comments now for folks on the collaborative first, and then open it up for public comment. Yeah. Representative Schmick, I know you were really concerned about doing the right thing for the patients and having a patient-oriented approach to this. Do you want to say a little bit more about that?
Very quickly, I just want to make sure that when somebody's looking at the video screen, that they know who's on the other end and that the patient can trust who's on the other end. I think that's important. Also, I'm pretty concerned about how we deliver this out in the rural areas, because that's all I represent, all critical access hospitals. And how are we going to deliver that care out in the rural areas? Those are probably the two things that I hope we can accomplish.
Yeah, Sean. Just to speak to your question about the written charter, I do think that that would help kind of establish a good kind of ground setting for what the collaborative hopes to achieve, and could perhaps, you know, more clearly identify for the group what's in scope, what's out of scope, and then set some short-term and kind of long-term goals as we look at, you know, a deadline of this December, which is coming up pretty quickly, and its ongoing needs. And just one of the things that I think would be great to share is from both the carrier and provider perspective is what is the current landscape, what is being reimbursed, to hear the input from providers about, you know, what are some of the challenges going on with using telemedicine as a delivery mechanism, and just being able to share and get that dialogue going.
Yeah, I just wanted to echo the importance of the patient and the consumer as well. One of the things that we have going this year with the Cambia health plans is an initiative to really promote those doctors that actually have a telehealth capability from doctor to patient. And we also agree with the doctor-driven approach with that as well. Cambia actually is an investor in Carina MD, which is really providing doctors the ability to offer their telehealth capabilities. We actually have metrics in place to really try to increase the number of doctors that we promote on our own website that have that capability. But from the consumer perspective, one of the things that we're really seeing is a really low utilization rate of telehealth. It's less than 1% of all visits. With the more engaged employers out there that actually have a CEO that's willing to promote telehealth and actually encourage their own employees to do it, we're still seeing stats of less than 10%. On average, it's like 4 or 5%. So I don't know whether it'll be in scope to address the actual value creation that's here, but definitely from our perspective, utilization and the lack of it actually is a pretty key
public
issue for
awareness,
us. Yeah.
raising awareness that this is available. Yeah, I think that's one of the most common things I hear is, you know, when people use it, like, oh my gosh, I didn't know how easy it is, and it's even available.
I was just gonna, we actually, Virginia Mason is working with Carina to launch our virtual care, and just expanding on your comment of engagement or utilization. One of the things that we see is a large drop off from the consumer of when they call in to actually use the teleconsult and then find out that it's not reimbursed by their insurance company. They elect to, you know, then not go forward with that visit. And so I think somewhere in there, if we could work on how we can expand policies and procedures or regulations to engage the consumer even further would be a great one. The other thing that I think we're interested in is we talk a lot about telehealth to the rural communities. Driving 6 miles in downtown Seattle is very difficult. So I would like us to look at, you know, telehealth from Seattle to Federal Way, telehealth to Seattle to Linwood, or Linwood to Bothell. And that seems to be, again, unless, and I'm new into the telehealth arena, but I believe there are significant limitations on reimbursement on that as well. And so maybe kind of how we can use this across all of Washington State to expand services.
Well, I'd just like to add on to that from a health information management perspective. I hope we come up with some documentation guidelines that allow for reimbursement, but aren't too prohibitive for the providers in having some specific type of documentation that isn't required for other type of visits. And then also making sure that that information is easily available within the electronic record or within the record of that organization, and making sure that the patient's privacy is protected.
Sheila's an expert on health IT and privacy and security, so definitely look forward to your expertise.
Chris?
Yeah, to look at the different deliverables, I think from my perspective working in group health, since for many of our patients, care coverage is combined reimbursements a little bit ancillary, although we have lots of patients who are outside of our network, it is material. But for me, I think the biggest issue is really making sure that where telemedicine occurs, that I'm interested more in the best practices and guidelines, that it's safe care, that it's appropriate care, that real value is being achieved, and that to the degree there can be some standards or interoperability, if you will, that care is transparent and visible, so we don't have these little pockets of different technologies that don't talk to each other. I would want to make sure that we try to avoid that. So those are my main goals.
What about your patients? For CMAR patients?
I like some comments of empowering communities, bringing access to care to underserved communities. That's a big issue, especially rural and underserved communities in general. This is a very good opportunity to address issues. As a medical director for 26 years in one of the largest community health centers in the state of Washington, one of my jobs is to recruit and retain providers, especially in underserved places, Ocean Shores, Aberdeen, Concrete. And so it's a challenge. And less I'm seeing an ability to recruit and retain good providers. This creates an opportunity to empower that medical community on the local side, recognize the work that these guys are doing, these medical providers, behavioral health providers. They really make a decision, their careers, to go and not necessarily sacrifice because they're pursuing a higher goal, but the net effect is they are not really linked to a collegial relationship that we may have in larger cities here. So the system in itself is built in a way that we almost penalize those really distinguished, highly qualified professionals trying to do the best in rural communities, in underserved communities. So this creates a vehicle, informational sharing. Senator Becker, you mentioned it, and others. This is not only a program, but the vehicle where best practices, knowledge can be brought to this medical group, this medical community, doing the right thing, and giving the patient in their community, which is, everybody knows. If I'm going to have trouble with disease, I'd rather be in my community being taken care of by a capable system provider and so forth. Everybody knows that. And so this creates that opportunity to close that gap, if you will, of the sheer lack of providers that we have in underserved communities. So I have very high hopes. We did a little bit of a trying through the ECHO down in Vancouver, hepatitis C and other diseases, chronic pain management is another one. So I know that this can work, but there are a lot of barriers here. How can we build? Who is going to be giving that provider the time? This is 15 minutes, 20, 30 minutes. How are we going to arrange it in that side? So best practices, reimbursement, billing codes, making sure that we do the right thing, keeping the patient's rights as priority. And so all those things need to be worked out. And hopefully we'll work it out in a way that recognizes the work that these individuals are doing, medical providers, and clinical systems are doing in those rural communities. This is a very good opportunity. So any CPT reimbursement billing methodology, I am hopeful that we recognize that and try to, if you will, try to err in that side of supporting those communities.
Great, thank you. Thank you, Ricardo.
Add on to that, as John mentioned, I am the board member for the NRTRC, and I just recently did a survey across the 7-state region, and a lot of the rural providers that I was talking to said, wow, that promise of telemedicine sounds great, but gosh, I am up to here with patients and keeping up with meaningful use and things. So how can we support those rural providers using telemedicine and using collaborative care models and ways that we can support those rural providers to provide good care to their patients and patients at home.
So, Dr. Scott, may I make a comment? Just so you're aware, You know, a lot of people think rural over in Representative Schmick's area where it's the other side of the mountains, but the second legislative district, my district, according to the Department of Health records that came out this year, we have the second lowest number of physicians per capita in the state. So rural can be right outside of Seattle, rural and urban and suburban. So I don't want to lose sight that rural can be close to Seattle as well. And I think that I just had to say that because so many people think it's only on the other side of the mountains when in fact it's right in our backyard on this side as well.
And I think this might be a good time to maybe go to our folks who are joining remotely. I saw Jeff kind of raising his hand. Jeff is a rural primary care doctor, and maybe timely to get your perspective, Jeff, on what's useful to you.
Yeah, I think so. I worked in Western Alaska in Bethel for 3 years, and I've been in Newport here 14 years. I have seen, more iterations of telehealth than I can even remember. And to me, the most effective use of telehealth is one that supports the local physicians. The one where you have patients sitting in front of a robot or a computer screen tends not to be well accepted and tends not to be as efficient or as effective as programs that support the local primary care providers.
Jeff, can you elaborate a little bit more on that?
Sure.
Like why is that more useful to you? Because I think that may not be obvious to a lot of people.
I'm not, the patient acceptance thing I'm not sure about. I think there are certainly some very tech-savvy folks that live in rural areas, but a lot are not by choice. Especially in Western Alaska, you have a lot of people living off the grid or living subsistence lifestyles. That's not their thing, staring at a person on a computer screen. From my perspective, in terms of supporting the rural family docs, why is that more? It seems like for one, as a family physician, you have a relationship with the patient. You understand the community, you live there, and so you have the nuances of that relationship that are lost in someone that's remoting in. And then two, in this day and age, a lot of healthcare, the knowledge is freely distributable. The knowledge is available, and you have to just get that to the providers and help them execute plans rather than working face-to-face with the patient. And then also, working face-to-face with a patient over a computer screen, it can be very, very difficult to execute plans. Okay, you need lab order. Okay, we want you to get this x-ray and this lab order. Okay, well, how do I do that? Well, let me print it for you. Oh, wait, let me hand it to you. No, I can't do that. Maybe I'll email it to your phone. Well, I have a flip phone. Does that work? No. So I think that's one of the execution with, again, a patient in front of a robot or a computer screen is challenging. Does that make sense?
Makes perfect sense. Thank you for sharing that. Francis, I know you've been involved in the formation of guidelines, and we had talked at ATA, you had some concerns about, just someone with not a whole lot of experience getting into trouble with some of the regulations. Can you elaborate a little bit on that and kind of what your perspective?
Certainly. Yes, I know. I'd like to just echo the sentiment of a lot of what I've heard this morning, and it's such a great comment. My background in telehealth is really in telemedicine has really been in the direct-to-consumer space. So I do hope that there would be room for that in this discussion. And there are challenges, as I know we just heard, but there's also advantages as well. And from the perspective of a health plan, and this is probably shared throughout the group, we really do struggle with the challenges in areas where primary care particularly is deficient and lacking, and that certainly, as we've heard, can be in urban areas, can be in rural areas, and that's a big challenge for us, as well as inappropriate use of healthcare services. A lot of our Medicaid members really use the ER as their primary care, and it's largely because they don't have transportation, they don't have access to care, they may be in areas where their PCPs aren't open beyond office hours. So it's really a challenge for us. And so really looking for right care at right time is a lot of the focus that I've worked on in the past. And actually, prior to coming to Molina, I was, full disclosure, the Chief Medical Officer at Carina MD. And so it's really been a sort of a full circle in terms of seeing sort of both sides of this picture. The work that I've done at ATA, to John's point, has really largely been in guideline development. And so I co-chair the National Committee on guidelines, standards and guidelines for primary urgent care that's currently posted on the website. And in doing that, it really became really acutely apparent, working both Carina and in developing these guidelines, that we really do need to set some standards, because a lot of providers, we're seeing this now as parity is coming next year, are coming into the space and really don't have the experience that many of you do with delivering care in a variety of venues. And again, I'm closest to the direct-to-consumer model. And having this one-to-one relationship, you really do need the infrastructure, you need the technology, the administrative capability, and of course the clinical expertise to be able to deliver a visit through telehealth that is different than, in many ways, than an in-person visit, and that needs to be accommodated. And guidelines need to be built to support that. So my concern is really three. One is direct access to the consumer, being able to offer these services where to support primary care and to integrate, not fragment, the great work that's being done in the primary care communities, offering a service 24/7 so that patients don't have to access the emergency rooms for care, and then also to be able to set some standards or at least some vetting process as new providers come into the telehealth space to make sure that we have some standards, clinical standards and benchmarking, and that guidelines are actually being adhered to at some level. So I'd like to talk about that in the future as well. Thank you.
Maybe we can turn to Representative Bergquist and Senator Cleveland next.
Thanks. This is Representative Bergquist. I want to echo all the comments I've been hearing. I appreciate all the contributions, and I don't think I have anything to add at this point. Just making sure that the patient's experience is a good one and it's useful. Thanks.
And this is Senator Cleveland, and also appreciate the great opening comments that have been made. My hope is that this collaborative will lead a proactive implementation and expansion of telemedicine in our state. And the vision for Washington is really to be a leader in this area and provide a model for other states to follow. So I think it's a fabulous start to have this talented group of experts gather together today. And I'm confident what we can accomplish together will ultimately improve healthcare for our citizens.
Thanks, Senator Cleveland. Maybe Lori, Adam, Mark, or Sue, do you want to say any other additional comments of what you're hoping to achieve?
This is Adam. I'll make a brief comment. I've been involved with another organization in setting some guidelines, and one challenge I think we encountered was, there's so many different telehealth modalities and so many different types of telehealth, from peer-to-peer to direct-to-consumer to store and forward, telestroke, tele-ICU, telepsych. I mean, all these different forms of healthcare service that are being delivered virtually, and thinking about putting down guidelines that are appropriate for all of those different modalities. I mean, you do have to kind of think about how a particular guideline affects a direct-to-consumer service line as opposed to a telepsych service line, or a store and forward, or a peer-to-peer consult situation. And so, I mean, I think it's important to as those guidelines are prepared to keep in mind the underlying values, which I think a lot of people have talked about: patient experience and ensuring high quality of care, integrity of the medical record people have talked about. But telehealth, when a lot of people, when they say telehealth, they'll think of their particular service line, where really we're talking about the whole range of healthcare that can potentially be, a portion of it could be delivered virtually, and thinking about how that could affect, how your guidelines could affect all those different areas is, is an interesting challenge here.
Yeah, and Adam, maybe if I can just pick up on something I think you were saying is, making sure we have clear definitions of what we're talking about. I think telehealth is such a huge kind of term that, you know, maybe having just some basic definitions for members of the public, maybe people who are trying to get educated, that there's lots of ways of delivering it. That was something that you mentioned, Senator Becker. And, you know, there are ATA guidelines that are specific to a lot of these specialties, so I don't want to reinvent the wheel. These are, you know, nationally vetted, so certainly some resources that are already out there. Mark, Sue, Lori? Yeah. Lori,
this is Mark. Can you hear me again? Did I get off mute?
Yeah, you're good. Go ahead,
I think Adam and the other speakers kind of summed it all up. The thing I would add is I'm not sure, you know, what this group can accomplish in terms of moving the needle, but I think we have to be aware that the needle's moving without us in terms of the generation of consumers. And we need to, if nothing else out of this group, it's great that we have a lot of legislators present. We need to make sure that any barriers that exist to meeting the needs of people that are seeking healthcare and who are the ones defining what they need, that we have the ability to do that without being too encumbered by the current view of whatever telemedicine and telehealth is. Because as has been pointed out by other speakers, there are lots of definitions and lots of use cases, but we're almost always behind the 8 ball.
Very good point, Mark. Lori, you look like you wanted to say something. And Lori, I think you might be on mute. So your lower left-hand corner.
Oh, there.
Okay. There you go. Good.
So just as another role that I play, in Oregon, we have something called the Telehealth Alliance of Oregon. So some folks may be familiar with that. And so I'm a part of that as well. And we went through a similar process and spent a good chunk of time working between providers, healthcare systems, and insurers about what those definitions were and making sure everybody felt comfortable. So that was the first part of our process when we went through something similar.
And Lori, would you be willing to share some of those documents with us?
Sure, I'm sure I have my notes, and we had groups. The Telehealth Alliance of Oregon was responsible for facilitating how reimbursement was going to be defined, in particular for telehealth services that were not happening in medical institutions. So that's what was recently passed in Oregon and was active as of January.
Thank you. Sue Stern. Sue, anything you want to add?
Sure. I guess I come at this with a slightly different perspective and more from the perspective of using telehealth as a platform or a technology to ensure access actually to high quality emergency care, which actually varies just as primary access to primary care does. There's a lot of variation across the state with regard to that for many reasons, both economic reasons, geographic regions, and specialty shortages. Some of that is related to shortages of emergency physicians, and some of that is related to shortages of some of the high-end specialties, whether it's plastic surgery or ENT. And so I see telehealth, emergency telehealth, for example, as an opportunity to bring some of timely critical care to more remote places, as well as to bring some specialty care to remote places that may not be as timely, but still as important. So for example, again, ophthalmology or maxillofacial surgery, you can use telehealth to bring that level of care at some level to more remote places. There are models such as that around the country. John, you and I visited University of Mississippi where they were able to do that. This can be a cost savings because there are many patients that sometimes end up being transported to a higher end facility farther away in the state, and sometimes you can keep those patients in their own community, which can be better for the family and the patient. using telehealth as well. So it's both bringing timely care to patients with critical and time-sensitive injuries and illnesses, and facilitating transfers and care on the ground, as well as sometimes keeping patients in their own community.
Yeah, I think I think Sue and I have heard this quite a bit, is almost every specialty service at UW-Madison, people get transferred every day and they don't need to be there. Either there was a pretty easy situation, or even in Seattle, we're going to be able to help them. So we really want to make sure that people are transferred when they really, really need it. So yeah, that's a. So what I want to do is ask a question next. We've talked a lot about what we want to do. What I want to ask, what should we not do? Okay, are there certain things that we should not do? Maybe start with Julie here.
Maybe I won't go on the we shouldn't do, but I was going to speak to parts that maybe haven't been mentioned. I agree with everything that has been said already, with even the EPIC integration, or not EPIC, but just EMR integration, the clinical guidelines. I think the part that we haven't mentioned is a quality assurance piece of, okay, yeah, we have got clinical guidelines, but these are so many different systems talking in different types of EMRs. Where we've struggled at Multicare is trying to find a digital platform that's HIPAA compliant, that allows two separate medical groups that are part of different organizations to safely be able to discuss cases that's legally protected under a peer review process. So that's been a challenge for us, and maybe that's something that could be approached as this work as well. And then the other piece, I'm a founder of a free clinic in the area, and want to make sure that we also are looking at this from the lens of, what if these virtual care visits we want to provide from any of these aspects, what if the provider wants to provide them directly for free, so that we're taking free clinics more to the virtual space of, well, we've got an hour of time that they want to donate. Is there a way for them to log into a central place and say, okay, I'll do some virtual visits for an hour? Somehow looking at it from the lens of patients that are still falling through the holes and gaps in our system. They don't have insurance, or they're in very remote areas and can't afford it, but maybe they do actually have an iPad, or they do have a smartphone of some sort. Is there some way we can provide that service to at least get them some level of medical care, so they don't end up at Harborview for a simple corneal abrasion or something like that?
So I have one thing that I think that we haven't really addressed, and we have a lot of physician extenders or provider extenders. I need to be comfortable, from my perspective, if I go see someone, I'd like to know that they have at least some level of training and some level of, okay, you've been reviewed by someone and we know you're able to do this level of care out there as an extender. I think we have to address that.
Yeah, if you read the ATA guidelines, they even explicitly say that before the patient selects a virtual visit, that they can see who some of the providers are. They have an option to choose, and they can see their qualifications. That needs to be totally transparent. And I'll just say there was a recent article in JAMA Dermatology that looked at the quality of care delivered by a lot of the national telemedicine companies, and that was probably the most common error that a lot of these national companies were making. So big deal.
Okay.
What I might just say, one thing is what I think would be useful is a toolkit. Kind of a starter kit. Say you're not affiliated with a big health system, but you just want to get started, whether you're in a rural area or maybe in an urban area with private practice. Like, what are the things you need to be thinking about? And so I really see this a lot as people think it's just about the technologies. They ask me, I want to do telemedicine, which platform should I use? And they haven't thought about maybe some of the legal implications and how to document properly. What are the billing codes? Some of the etiquette, I think Representative Schmick talked about that, you need to show your badge. You need to make sure that your door is closed and that the people on the other side are in a private and quiet place as well. There's all little things that people don't think about. So I almost envisioned a checklist that people could have and say, okay, I want to get started, and these are all the things that my group we need to have accomplished. So just put that out there as an idea. Francis, you had a comment about that?
Yes, John, just to echo that as a starting point, the ATA does have a toolkit of sorts, as you described, sort of a step-by-step on how to set up a
a virtual practice that does include legal, administrative, clinical, and technical requirements to be able to set up kind of a program.
Okay, so maybe have some kind of a link or called out on our website. Okay, great. Scott Kennedy, I apologize. I didn't call on you. I'm not able to see you. So Scott, did you want to say anything about what we've been talking about?
You bet, and not at all. I wasn't able to bring Zoom up, unfortunately, here, but yeah, and I would agree with much of what's been said. I think, you know, an emphasis on making sure that we have high quality, kind of evidence-based criteria for the visits and looking for convenience for both the patient and the clinician. I think the access picture is really important, expanding access to specialties and critical care for EICU type capabilities, but also for having regional standards of care where we're working off the same evidence-based standards permeating into the rural area. And certainly rural areas tend to have older communities. I know we're at least 25% over age 65 here. So transportation issues are difficult. Having access to very difficult to recruit specialties like rheumatology, endocrinology, neurology, things like that, where it's appropriate for telemedicine, I think are important to develop. The other thing is just the opportunity to decrease infection control exposures at the clinics and the emergency rooms and urgent care centers and so forth. And then a few other areas that I think we might think about is, you know, we've got an opioid overdose epidemic in Washington State, certainly throughout the nation, but we're working on it in Washington State. Many organizations are working together. Can we look at how telemedicine might most appropriately be carried out and unfettered to address that epidemic? The other thing I'll mention is that I had the opportunity to meet Dr. Paul Glassman from California, who's a pioneer in virtual dental and oral health through telemedicine. So he's the director of community oral health and director of Pacific Center for Special Needs Care, where he's at, but working on a dental home virtual community program. And while I think it's important to get 24/7 access of telemedicine capabilities, growing telemedicine capabilities into the hands of the consumer, I think as we look at, you know, the community health pictures together, something that we're beginning to do more and more, it'll be good to look for opportunities for telemedicine to move us further towards community health. So things like addressing the opioid epidemic, possibly virtual dentistry, so dentistry isn't so practice site dependent, moving patients away from the long waiting times in the emergency room, certainly, but even in clinics and things like that take them away from their work. And then the one thing I might throw out there just to see if anyone knows of a model out there or anything like that, but what about tele capabilities for a disaster scene? If there was an epidemic somewhere in Washington or some other type of disaster, are there capabilities being developed somewhere that might help us more effectively address disaster scenes?
Great question, Scott. And I might actually call on Dr. Stern in a second to comment on that, or maybe even Dr. Delacaro might know. I wanted to use this opportunity to maybe open it up to the public. And Scott, you mentioned the whole opioid crisis, and I just want to invite first Katie Colon from the Washington State Medical Association to comment on that. And then I know there were a couple of people here in the public who wanted to chime in. I'll give an opportunity for that. So Katie, do you want to?
Thank you.
Yeah.
Thank you, Dr. Scott. I don't mean to impose on your space, but I'll get near the microphone. Again, I'm Katie Cohen with the Washington State Medical Association. These worlds really are merging, and the Washington State Hospital Association and the Washington State Medical Association just joined forces for a joint opiate task force to look at 3 legislative proposals addressing the opiate crisis and epidemic and 3 non-legislative proposals. And actually, we've been in conversation as well with Dr. David Calvin at the University of Washington with his telepain clinic. So really these worlds are merging. And again, I'm a member of the public, but if I could be helpful in providing any of that resource or expertise or connecting you with who you need to as these worlds get closer, please let me know. Thank you.
Cindy, I know you had your hand up. Anything you wanted to add?
Yeah.
And maybe if you can, members of the public, if you could stand up and please tell us your name and where you're from, that'd be great.
I'm Cindy Jacobs. I'm a nurse attorney working at UW School of Medicine. I've been working on telemedicine for several years, and I teach telemedicine and the law at UW Law School. So this is very great interest to me. I follow it very closely. My thought is I would love to see the collaborative make a concerted effort to comprehensively identify barriers. Some of those are beyond our control. For example, the persistent gap in Medicare reimbursement. Other states and licensure portability is an enormous obstacle. Also, access to care, I think, is what we're all after, and not just thinking of people in isolated areas, but people who have transportation problems even in urban areas, or, for example, patients in nursing facilities, for whom or mostly assisted living facilities, because they typically do not have medical staffs. And we have patients who don't find it easy to get to the doctor, and they have chronic illnesses. So I would love to see the collaborative try to comprehensively identify what are the barriers, what can we address through legislation at the state level, and how can we get creative to address some of the others. Reimbursement obviously is a big issue, and we've made a good start in Washington, but licensure portability still affects our faculty, particularly in the WWAMI region, which is where we provide most of our care. And then we've got, Medicare sitting over there like the 800-pound gorilla. That would be, the other thing that I look at a lot is the evolving standard of care. And I think one trap we can fall into is to look at telemedicine as a treatment. It's not, it's a treatment delivery. We're evolving. It's the same treatment, it's just delivered in a different way. So rather than trying to, and I've seen some states do this, they try to articulate a standard of care for telemedicine. We're really adding layers to the existing standard of care. And so I think we could go down a rabbit hole trying to take telemedicine over here and say, telemental health care looks like this, when regular mental health care already has an existing set of standards. We have to layer on it because of the way, it's like using a piece of equipment. It's more of a making sure people are appropriately credentialed and privileged. I mean, I could go on forever, but so basically I would just love to see the collaborative take as broad a look as they can at all the obstacles to telemedicine and telehealth. And definitions are obviously a big issue, so.
I know we have members from the MCLOT. I don't know if you're on that spot, but and also members from the Department of Health. Matt, others, this is a time to speak up.
Experience has shown me that I'll speak loud now, so close to the mic. My name is Michael Matthews. I'm the Deputy Executive Director for the Medical Commission. The licensing piece falls on me. I will say that we're actively pursuing everything we can to shorten the licensure times, including using a uniform application, online application with the department. We're looking at the interstate licensure compact to get that adopted. One thing I would point out is that we get approached by various companies, and I'm the telemedicine lead for the commission, so I'll just point that out. We get approached by various companies, and really we don't have any concern with things that you're talking about, University of Washington, hospital-based primary care, that kind of thing, using community centers, and I love the free clinic idea, that was great. But the direct consumer thing is what, in some spaces, offers us concern. Karina ND, I meet with them on a fairly regular basis. I talk to, there's a group called City ND coming from New York that's doing urgent care. They're opening up in Seattle. Zoom Care is doing, talks to us and tries to tell us what they're doing. But then there's companies who are trying to do app-based care, or there's a company out of the Midwest that's trying to say, well, you don't need a doctor, you just need a logic engine. Yeah. So it's one of those things where we have concerns about those kinds of applications where the companies are chasing the money and they're not chasing the patient factor. We've had guidelines in place since 2014 And as you guys were talking about, it was just checking off the list, making sure that the EMR is connected, identifying the patient and the practitioner, being able to figure out how you're billing. And the standard of care is the same no matter where you're at, telemedicine now. There are community standards, but I agree, don't put different layers on. It's just another characteristic.
Thanks, man. Matt Levi, you can.
Matt Levi, CHI Franciscan Health, and I just want to say this is a great collaborative, and thank you for making this a transparent process. So to me, just being able to see all the people in the room here and online, please continue to make this a transparent process. It's very exciting to see the energy and the expertise that is here. So, so kind of as we go through this together, I think this whole group really is going to help transform not just those on the collaborative, but all of us that are able to participate. So thank you very much.
DOH. Oh.
Hi, I'm Bonnie Burlingham. I'm from the State Office of Rural Health at the Department of Health. And I mean, I agree with a lot of what's said. We do have a lot of data on sort of access to care and availability and what's considered rural and what's considered urban. So please, at any time, if we can help provide some of that. We've also have a small group at the Department of Health that's been looking at how the Department of Health can look at specific regulations that are barriers to providing telemedicine and telehealth services. We haven't really found that many. There's quite a few people all coming together. And so if there are specific regulatory barriers that the Department of Health can address, I can bring it back to the group and see if there's anything that we can, help put together on information for it. So.
I'm just wondering if there's anyone in the members of the public who can speak as a patient. We were really hoping to get someone on the collaborative as a patient representative. No one really applied under that. Is there anyone who feel like they could speak as a patient?
I can speak as a patient. I had a procedure done in Seattle, and I was in the hospital for a couple days a few years ago. And my drive up there was a 4-hour drive just to get there I live out by Mount Rainier, and because of traffic, et cetera. And so for going up for the surgery, I didn't mind that, but it's that drive on the follow-up. Okay, so the follow-up care, to me, it was crazy that I had to do wasted an entire day when in fact we probably could have done most of that. So from a patient's perspective, I look at, what's more convenient for me and how would that actually make it more convenient for the doctor as well. I always also think when we were talking is, I don't want the doctors to lose or the providers to lose that on hands with the patient. Ultimately, I don't want a provider to be sitting in a room doing telemedicine all day. And that would make me very nervous as to what that doctor would really remember about me, et cetera. So, but as a patient, it's transportation, and it's not wanting to spend 8 hours just to go for a 15-minute follow-up. That's my patient experience.
Another comment from a patient perspective. Would much rather at 9 o'clock on a Sunday evening be able to get on my phone, have my kid's throat looked at and be told we don't need antibiotics, or we do need antibiotics, so either way. So we had one of these the night before Halloween, and my son had a horrible sore throat, met most of the center criteria, so we did a virtual visit. But way more valuable for our time, even though we didn't have transportation issues, it was all other sources other than ER is closed at this hour of day and night. And it's really, I want to get something started before, because we want to be able to go trick-or-treating the next day. So from a convenience perspective was very helpful, and to also avoid the 2-hour wait or the 3-hour wait. The alternative for us wouldn't have been going to the ER. It would have just been missing out on trick-or-treating the next day. But it still was, from a consumer perspective, that was important to me at that moment and to my child at that moment.
And to follow up a little bit, the other thing that was frustrating to me is to call the ER and talk to a triage nurse, and the only response I get is, you need to come in.
Default.
That is something we need to, yeah.
Maybe if I can speak for patients who maybe come from a poor background, and we all assume that everyone has a smartphone or has a computer that has the technology. And I know that Francis, you and I have talked about this, and Ricardo, that we somewhat assume that everyone has internet, everyone has a device. So when we talk about access, it's not just knowledge about it or having the setup, it's actually having some of the equipment. So I hope that there's some awareness to that on this collaborative and ways that we can make it truly accessible for everyone.
I think another perspective that hasn't been mentioned yet is the EMS services. So I know we have several different trials in some of our regions where they're either putting a nurse practitioner on the car to be able to deal with these lower acuity things of, no, you actually don't need to go to the emergency room, and we know you're going to land there if we do nothing for you. So let's at least try and address your question here, or let's call you a taxi and get you to an urgent care for a more appropriate level of care. But I think there's some out there doing trials of, let's just bring an iPad along with us and see if we can, if they're not a clinician on the car, to be able to have those types of visits. But again, I'm sure they're running into the reimbursement and that these are all just little pilots. How do we get those services paid for so that the patient can get the care they need? And if they really don't need to physically go anywhere, great, but we've brought the technology to them with somebody who knows how to operate it as well, because that's another barrier. Even if we have our iPhones, a lot of people don't know how to work it enough to be able to get as far into the app or whatever to have that HIPAA compliant interaction.
I think what I'm going to do is I'm going to turn to what New Mexico is doing for just a reference of what other states have done. And so this is a website I'm going to share now, share my screen. So let's go. Hopefully, can you guys see this now? It's like a green background. It says the New Mexico Telehealth Alliance. Francis and Jeff, can you see it? Okay. He's head nods. Okay. This is an alliance that's been ongoing for over 5 years, and maybe just start with what their vision statement is. So New Mexico will serve as an exemplary national and international model by integrating telehealth into our healthcare delivery system to provide all New Mexico communities timely access to confident, reliable, and affordable healthcare. So pretty far-reaching statement is really getting at telehealth as a tool, as I think others have said. Their mission statement is to provide a forum for individuals and organizations to improve the health of New Mexicans through the collaboration and sharing of health resources statewide. The Alliance seeks to enable the development and delivery of technology-assisted programs that promote access, utilization, and affordability of telehealth services. So I just kind of want to reflect back on kind of what we said. It's a pretty broad vision and mission statement. Is this, let's see if there are things in there that people don't jive with or things that are left out. This is obviously just a starting point, but yeah, this members of collaborative, what do you think?
On first look, I like it. I like the fact that it's not just looking at it locally, and they have a goal to be the best. And I like that part of it. But what is the best?
Yeah. And this has also led to the development of the Interstate SIG Special Interest Group at the ATA, kind of headed by some of the founders of the New Mexico Alliance. Yeah.
Can you expand upon that a little bit?
Yeah, Dr. Dale Alverson, who is from the University of New Mexico and has been involved in a lot of things, ex-ATA president. Actually, the Four Corners Alliance that he helped start, they transitioned into something new, and they wanted to broaden it within the American Telemedicine Association. and they wanted to pull together a group of folks interested in dealing with and looking at interstate issues, whether it be licensure, credentialing, other sorts of things like that. So that's just getting going and being recognized as a formal group within the ATA.
But I guess when we started talking about the collaborative, I envisioned something like a website like this that would be, you know, a standalone website, and that the people could come to it, and there would be, you know, little subcategories like initiatives or a toolkit that we could kind of carve out, link to best practices. You know, there'll be some news, whether there's, you know, conferences, webinars in our TRC, maybe some legislative updates, obviously. So resources and link here, and then a way to download some of these forms and things like that. So is this maybe a template we could work from, or what we have here in Washington?
I just want to add what I really like about that is the integration component, that they're viewing telemedicine or telehealth as part of a larger healthcare delivery system, and I think that's important. My slogan around work is that virtual care is real care, and just think about it in the exact same way, the same parameters and expectations as face-to-face care. So I like not thinking about it as ancillary, but really as integrated into a larger picture. You started to go earlier around what would we not want to happen.
Yeah.
And so just for me, my nightmare scenario would be that it's maybe a poor analogy, but thinking about like Uber, if you just got on your phone and hit a button and within a few minutes some provider somewhere popped up to see what you needed, I worry that telemedicine could be disruptive to the healing relationship between a patient and provider, and I think we need to be thoughtful that it's actually enhancing that and not fragmenting.
Just to expand a little bit on that, I strongly suggest that the PCP-patient relationship should be spurred. We could enhance if we could release this program system that we have. That's a general statement. They have a lot of details in it, but I think overall we should try to strengthen that relationship somehow. The fact that we are delivering the specific treatment of care because we don't have it in a particular community, that doesn't necessarily mean that in itself becomes a provider, that somebody has access to it and there's no need to be part of a system or a PCP program, because that we go to the Uber better experience, and I would not support that.
So just a question. So this is for the collaborative or the peer-to-peer, not the patient.
You know, it looks like it's for patients as well. You know, this is it's public facing. So if you were a patient, you want to know, hey, what is telehealth? But there might be some, and this is still pretty basic. But I would envision there being some definitions. You know, like what is telehealth?
And the reason I'm asking that is when I see membership, that always makes me nervous of what are they going to ask of me to be a member, you know, type of thing. So that may be just mentally a barrier for some. But there's what I would like to see if we do this is some way for the patient to provide feedback so that we can learn and grow from the patient.
And just a word about the membership in New Mexico. So the way that they pay their staff is that people have to pay to be a part of it. Okay. I concur with you. I don't want this to be exclusive because you don't have an ability to pay for it.
Right.
And I think the fact that we've started out with a little bit of funding from the legislature is a good start. If there's anything on there that makes me a little bit concerned is the membership aspect of this. Yeah.
So then if we went down this road and there's a limited amount of funding, we would have to figure out how we're going to make this sustainable, right? And that we wouldn't just create it and 8 months down the road. It's just
That's plan 2.
Yeah. We talked about technical assistance. Mm-hmm. Other states have, you know, back when the technology was really expensive, there were statewide networks. When the technology was over $1 million, that was one of the roles of the statewide networks. I think now with the technology getting cheaper, there's less of a need. That's why I know they've done that in Mississippi and Missouri. They've actually bought equipment. Other comments, reactions to this vision statement? If I put it out there and people can read it, follow up, maybe we'll have an opportunity for people to give edits and add it. I think we want to allow it to be pretty broad, but also that we know that we're on task.
Yeah, I think when we're considering a website, there are different approaches, and everyone is coming in with different interests. But because it's such an unknown entity and there are so many facets, it might be helpful if we're serious in phase 2 to develop a platform like this, is to consider it's all transparent, but perhaps a section that's just for providers, so that that's a resource where they can go find out what the latest legislative bills are, and when does the parity agreement kick in, or what if I'm interested in delivery of virtual care, what are the legal ramifications, but sort of having a separate interface or location for providers. Not that patients can't go see that, but it's just that it kind of directs you, what are your resources at the state level, at the local level, how can you get involved, whatever it is. But this is nice, and there's sort of broad strokes and high level information, but there's a lot of granular stuff that I think people would really find helpful. How do you report something that you think might be fraudulent? Whatever, there's just so many facets that could be developed. And then I guess my question is, how do we provide sustainability of that website? Because there's nothing worse than surfing into something and realizing that it's not up to date. And this is kind of minute to minute, transformation here.
Maybe I can ask a question to Representative Schmick and Bergquist, Senators Cleveland and Becker, about their experience with similar task force. Maybe if you guys have been on it, and if there's something that we can look at in Washington State, maybe in a totally different area. Do you have any experience to share on similar task force?
On thinking.
I have had experience on a lot of task forces, and my biggest fear, we're on the Joint Select Committee task force, and we co-chair that. Representative Cody and I do, and Representative Schmick's on that. But what always concerns me is we might have this grandiose idea and it goes so far, and then it just kind of gets left in the wayside. So I think if we're looking at this, what I'm hearing is really we have to look at, number one, what is our starting point? And that's what I think we need to do by December. But by December, we have to be able to also say, in order to do this starting point, we would like to request this amount of money in order to do that. And then go to building block 2 for the next part of it, et cetera. We're going to have to do it incrementally. That budget is only so big. And then look for resources outside of the legislative body that maybe want to be able to help fund that. We've seen that partnership before, and that would be a really good move.
I agree that I wonder some of the comments that you make are outside the scope of what we're doing here. I mean, we're starting out at the ground floor. And I don't know whether or not you're down the road a ways from where we're starting at this point. The fact that you want something to keep up with, like doctors, you may use the example of doctors and current bills that are before the legislature. I mean, my goodness, that is like you were saying, a minute to minute, because they change so quickly. And I wonder if that's still beyond the scope of what we're doing here. I view this as getting some guidelines put in place and some standards so that we can move ahead with it. I guess I just want to get the cart before the horse. If you take too big of a bite, I don't know whether we can deliver. And I guess that's my concern. Small steps, not big steps.
It was just in the spirit
I understand.
of, you know, what we're looking at in terms of a resource on the internet. Thank you.
So if I can interject, I look at this as we can dream. We can do the big dream, and that's how you get to what can become reality. So I don't want to take anything out of the scope just for the fact that when you mentioned to report somebody that might be fraudulent, I'd rather get to that person that may be inadvertently, not without the knowledge, the proper knowledge, billing incorrectly and becoming fraudulent. I'd rather be able to get to them prior to that and give them the education so that they don't become fraudulent and help them rather than fine them or take their license away.
You will find I'm very pragmatic, practical, and we got to pay for this. And that's so that I'm always come from that perspective.
And this is Senator Cleveland. I just wanted to add to what's been said that, you know, we've discussed many different aspects, I think, this morning already of what the work of the collaborative might encompass. And so I would suggest, or perhaps, or put forward that as a part of our work, we might want to also add putting some effort to an implementation plan and timeline.
Okay. Well, I'm cognizant we've been talking for about 90 minutes now, and people might need to take a bathroom break. So it's okay. I suggest we take a 10-minute break to get some coffee and find the restrooms, and we'll adjourn back at 10:10.